1919 was an auspicious year in history. The First World War ended, ushering a drastic change in the world order. The Philippine Islands had been a U.S. territory for 2 decades and was promised independence under the Jones Law of 1916. Progressive reformers saw the country and its people as a major target for modernization, and education was its main weapon. 7 forward-looking Filipinas came together in 1919 to create a school where young women could gain the knowledge and skills that would make them modern women. Paz Marquez Benitez was the first president of the Philippine Women's College. Jose Abad Santos was its first chairman of the Board of Trustees. Francisca Tirona Benitez was the second president, and with her husband Dean Conrado, guided the school from a house on A. Flores Street to its iconic Taft Avenue campus. In 1932, the college became a university, making PWU the first university for women in Asia founded by Asians. It provided a space where innovations in education flourished, and young people were encouraged to be the best that they could be. For over 100 years, the Philippine Women's University has been known as a leader in quality education. In 1934, PWU moved into its main campus on Taft Avenue, and since the 1970s has been co-educational. Located in the heart of Metro Manila, it is easily accessible by public transport and surrounded by affordable housing. Today's PWU offers undergraduate and graduate courses in several fields of study. Its business and management programs are responsive to the needs of industry, using evolving technology for global competence. PWU graduates excel in arts and sciences, education, social work, and diplomacy. Its fine arts and music programs have produced outstanding graduates through a holistic education that treasures heritage as well as excellence. PWU has pioneered in fields such as food science, nutrition and dietetics, medical technology, pharmacy, and nursing. PWU continues to play an essential role in producing graduates who possess the skills that make them competitive in the country and anywhere in the world.
We are a united community.
We may not be blood related,
but we Patriots are one big family.
Being part of the PWU community strengthens us.
Through the years, we support each other through good times and bad times.
We Patriots always have each other's back.
It's a big honor to be part of a community that is open to the ideas of each other.
Drives us to excel, and be the best version of ourselves.
That's the standard of excellence that we Patriots strive for.
I'm thankful that this community lets us be who we want to be.
We thrive because we accept each other for who we are.
And like a family, we treat each other equally.
Actually, PWU gave us a home and helped us to be a patriot in society.
We may have different individual drums and instruments,
but we march with the same beat together as one united community.
Do you want to march with our community of patriots?
I am a patriot.
I am a patriot.
I am a patriot.
I am a patriot.
Good afternoon, everyone. I hope everyone can hear me clearly. How are you feeling today? I hope you're doing great as much as I do. By the way, this is Prof. Arvin Alcantara, a student of Masters of Arts in Nursing with major in Medical and Surgical Nursing from the Philippine Women's University, Manila, and I will be your moderator for today's event. And I am thrilled to welcome you all to a forum specially facilitated by our Master's section entitled Advancing the Core Competencies of Nurses, Acute Stroke Management, and rTPA Administration. You are definitely in for a treat, and together, let us indulge ourselves in improving our competencies as stroke nurses. To officially start our program, let us put ourselves in the presence of our dear Creator through an invocation followed by the Philippine National Anthem.
di mo'y buhay. Lupang hinirang, duyat ka ng magiting. Sa manlulupig, di ka pasisiid. Sa dagat at bundok, sa simoy at sa langit mong bukaw. May dilagang tulad, awit sa paglayang minamahal. Ang kisap ng watawat mo'y tagumpay na nagtitindig. Ang bituin at araw niya kailan pa may di magdidinig. Lupa ng araw ng luwal at ipagsinta mo'y langit sa piling mo. Aming ligaya dapat may mga api ang mamatay ng dahil sa'yo.
To help me welcome you all today, let me introduce one of the facilitators of this webinar and a practicing nurse from Adventist Healthcare Oak Medical Center in Maryland, USA. Here is Mr. Ryan Udelmo for a short welcoming remarks.
Okay. Good morning to everyone. Can you hear me?
Yes, Sir Ryan.
All right. So good morning to everyone in the Philippines. Excellencies, colleagues, ladies and gentlemen, I join my colleagues in welcoming you all to the webinar Advancing the Core Competencies of Nurses, Acute Stroke Management and rTPA Administration and Updated Prevention and Control of COVID-19 Progress and Challenges. I know COVID-19 has ripped off many lives and families in the Philippines as well as here in the United States. But as Filipino, we are known to be the most resilient individual across the globe. I also would like to give a big thanks to the co-chairs as well as those working committees for organizing this timely manner webinar, particularly to the group, Dr. Alzate, and last but not the least, the PWU School of Graduates and School of Nursing. Here we are in 2022, a year that is certainly none of us will ever forget, as well as the COVID-19 pandemic that threatens all the lives, as well as the collateral damages in patients inflicted, particularly the stroke. As we all know, every 40 seconds, someone in the United States has a stroke. And meanwhile, in the Philippines from 2009 to 2019, according to the recent statistics, stroke remains the second leading cause of death and one of the top 5 leading causes of disability in the Philippines. Thus, the true stroke prevalence is uncertain and cannot be represented by these numbers. But reported estimates vary from 0.9 in 2005 and 2.6 in 2019 of the population. Thus, it requires us, particularly nurses, to be more empowered and be more competent in terms of advancing our knowledge and clinical decision-making in practicing, detecting, and helping the physicians in diagnosing the acute stroke in its early stages. Particularly, we're also required by these events to be on top of our knowledge in controlling and doing the surveillance to prevent the surge of COVID-19, particularly in our home country. With that, I thank all in advance, all the participants in this webinar for your contributions and your time that you have given to us to provide an advanced education to all of you. With that, I welcome everyone and thank you. Enjoy the webinar.
Thank you, Sir Ryan, for that message. Again, let me welcome you all to this event. As we all know, stroke has been one of the leading causes of death and illness in the Philippines. Even before this global pandemic, and as we gear towards the new normal in healthcare, it is time to talk about how we can easily or timely assess potential stroke patients, how we can decrease or prevent such risk, and how we can provide prompt and the best stroke nursing care to our stroke patients. Stroke is a manageable illness, but time is essential and critical that greatly affects outcomes. As the primary provider of care to such patients, it is our responsibility to continuously strive for the best care possible by developing our nursing core competencies. And that is the whole aim of this webinar, to help us nurses develop a more keen clinical eye and a competent decision-making skill. Just a few reminders to our participants: make sure to turn off your audios during the session or mute rather. We will be answering some of your questions after, so feel free to key in your questions in our chat box. Or if you wish to participate or ask to participate, please do unmute or open your video so we could hear from you later on. Also, we will be asking you to complete a post-evaluation link later on. So are you guys ready? Without further ado, let us now proceed to the highlight of this afternoon's event, the discussion on how we can further improve our stroke assessment and management, as well as updates on the rTPA administration. We are honored to have a neurologist with us today to share his expertise. Our speaker holds a bachelor's degree in biology from University of Santo Tomas and is a graduate of Doctor of Medicine from the University of the East. He had his residency training in adult neurology from the International Institute of Neurosciences of St. Luke's Medical Center. Also had his internship program in Quirino Memorial Medical Center. He is a fellow of the Philippine Neurological Association, a member of the Philippine Medical Association, a member of the Philippine League Against Epilepsy, and also a member of the Stroke Society of the Philippines. He is an active consultant here in Calamba Medical Centers and surrounding hospitals around the province. He is also the head neurologist of the Acute Stroke Unit of Calamba Medical Center. I am honored to give the floor to Dr. Mark Christopher Palanginan.
Thank you, Ralph. Good afternoon, everyone.
Good afternoon, po, Doc.
Good afternoon, Doc.
Good afternoon, Doc.
Okay, so I guess we can start. Can I share my screen? Okay, can you see it? Can you see it now?
Yes, po, Doc.
Yes, Doc.
Okay, so let me just hide this. Okay, so good afternoon, everyone. I'm here to talk about acute stroke management, and this would be the outline of our lecture. So first, we have to define what stroke is, and you also have to know its epidemiology and anatomy, and of course, what causes it, its presentation or signs and symptoms, and its treatment and management. So first off, what is a stroke? A stroke is a sudden interruption in blood flow to the brain that results in a neurologic deficit. In other words, it is a brain attack. So it's like heart attack, but it's the brain. Now, it is an emergency and it can be fatal, but it is treatable and preventable. And as neurologists, we always consider that time is brain because every second counts. So there's about 1.9 million neurons lost per minute in a stroke. So of course, we have to be fast and we have to take into consider the time. And as you can see here, per stroke, neurons, billions of neurons are lost, and it accelerates aging by about 36 years. So that's how important time is. So really, every second counts. Now, for stroke, as Ryan and Arvin said, it is the second leading cause of death worldwide. And in the Philippines, mortality is 82.8 per 100,000 person years. And in 2014, there's one neurologist for every about 320,000 Filipinos. The urban center neurologists have 67%, and the rural center neurologists occupy 33%. Now, in Calabarzon, as of 2018, its population is more or less 15 million, and in Laguna, 1 million. This is the second cause of mortality in males and fourth cause of mortality in females. Now, when it comes to stroke management, we have to learn and we have to be familiar with its anatomy. So here's an HL view of the brain. And in here, of course, when we talk about stroke, we have to understand and remember all of these blood vessels, the arteries, because the arteries themselves are blocked or they rupture, and then the stroke happens. So we have to remember these. The most notable ones are, of course, the anterior cerebral artery, the middle cerebral artery, the posterior cerebral artery, and we have the basilar artery, and the spinal arteries. Now, this is just a view, a coronal plate. It just shows the anatomy and of course its corresponding blood supply. So in here, you have to be familiar with the ACA and its branches, the MCA or middle cerebral artery division, the superior division, and the inferior division, its deep branches, and the posterior cerebral artery and its branches, the inferior part of the brain, and anterior choroidal artery is a branch of the internal carotid artery. So in just to orient, this is the superior view, it's the inferior part of the brain. And this is the axial cut of the brain. So again, we have to be familiar with the anatomy and the blood vessels. ACA, anterior cerebral artery and its branches. The middle cerebral artery, the yellow one, and its branches. PCA, posterior cerebral artery and its branches. So for example, if we have an occlusion in the PCA, posterior cerebral artery, so the occipital lobe will be affected, making the patient go blind. Usually on one side or one laterality. If the affected portion is the MCA, superior division, so it occupies the motor motor part of the brain, so the patient will have a paralysis. So we have to be accustomed to the anatomy and its blood vessels. Now, let's go to its etiology. So to talk about the risk factors. So there are the non-modifiable risk factors, the treatable risk factors, and those with lifestyle risk factors. Again, non-modifiable, as the term implies, those that the patient cannot change, treatable, those the patient cannot eliminate but can be treated, and those that involve lifestyle choices for the lifestyle risk factors. First off, for the non-modifiable, we have, of course, age. So age, the risk of stroke doubles per decade after age 55. So age is very important factor, as well as gender, because more males suffer from stroke than females. Also, a previous stroke or a transient ischemic attack doubles its risk, and blacks also can have more strokes as compared with Caucasians. Now, those with treatable risk factors, of course, we have hypertension. Hypertension is the leading risk factor for stroke. It accounts for about 42% of risk of stroke. as well as cardiac disease and atrial fibrillation, and diabetes mellitus and dyslipidemia. As for lifestyle, we have smoking, of course, and alcohol abuse, obesity, we have physical inactivity, and illicit drug use. For physical inactivity, it accounts for about 30% risk of stroke. So that's why they say galaw-galaw para hindi ma-stroke, because that's true. Physical inactivity accounts for a major part of stroke. Now let's go to its presentation. Now, usually, stroke occurs as a sudden one-sided weakness or numbness. And sometimes they present with trouble in speaking or understanding. Of course, it depends on the part of the brain which was affected. Sometimes the affected area is the occipital area. It can be loss of vision or doubling of vision when it comes to the brainstem. There can be severe and unusual headache, especially in bleeds, in hemorrhages, in dizziness and gait imbalance, and those affected with a cerebellar stroke or posterior circulation stroke. Now, we have two major types of stroke. Of course, we have the infarction and the hemorrhage. So first off, for infarction, it accounts for about 70 to 80% of strokes. And usually the most common is thrombotic cause. So for thrombotic cause, usually the arteries are blocked off by fatty deposits. Hence the term thrombosis. The second one would be embolic. So there is an embolism. Usually the embolus comes from the heart in a patient with atrial fibrillation, and then it lodges in a large artery. That's why, as you can see here, usually in thrombotic strokes, it may be a big stroke, but it's not that big as compared with embolic strokes. So if the stroke is big, means a large artery is affected, usually it is an embolic stroke. Now, here are the causes. As I've said, fatty deposits, because it occurs when the plaque accumulates on the arterial wall. Also heart conditions, especially atrial fibrillation and blood disorders. So let's go to hemorrhage. Now, hemorrhages account for 20 to 30% of stroke. It can be intracerebral or subarachnoid. Intracerebral strokes occur, of course, when the blood vessels burst or rupture, usually because of high blood pressure, and the blood pours out into the brain. For subarachnoid hemorrhages, of course, usually occurs with ruptured aneurysmal bleeds. Now, the usual causes of hemorrhage is, again, high blood pressure and blood disorders or an aneurysm. Now, let's go to some stroke myths and facts. So myths, stroke cannot be prevented. Well, in fact, up to 80% of strokes are preventable. They say that there's no treatment for stroke, but any sign of stroke, you have to call for help, and treatment may be available. And stroke doesn't just affect the elderly, it can happen to anyone. I have patients who are as young as 6 years old. They have a heart disorder by the stroke. Some have blood disorders by the stroke. And stroke happens in the heart? Well, no, it is a brain attack. They say that stroke recovery only happens for the first few months after a stroke. Well, in fact, stroke recovery is a lifelong process. They say strokes are rare, but it's not. It is the second leading cause of death worldwide. And some strokes are hereditary. So you have to be careful, especially in those with family history of stroke. And they say that stroke symptoms go away, so you don't have to see a doctor. Well, there are some strokes which are transient, and these are called transient ischemic attacks. They are warning signs to an actual stroke. But after a TIA, a transient ischemic attack, there's a double, there's a risk to double the stroke. So it is a warning. So we have to see a doctor immediately. Now let's go to management. Of course, when the patient comes in the hospital, the ER sees the patient first. We go to the triage, and then ideally the ER team examines the patient, and then they do an NIHSS or the National Institutes of Health stroke scale. And then if they see that the patient has a stroke, if they can identify that the patient has stroke, then they call the brain attack team. Brain attack team is a hospital-based stroke team available around the clock, 7 days a week, in order to evaluate within 15 minutes any patient who may have suffered a stroke. And the stroke team composed of a doctor or doctors, nurses, pharmacists, physiotherapists, social workers, and dietitian. So this is a team effort. So it's not just the nurses, the doctors. It's a team effort. Now, when the stroke team sees the patient has a stroke, usually blood tests are done and brain imaging is done as well. Of course, we have to review the symptoms and review the brain imaging, and we have to decide if it's for thrombolytic therapy. So this can be a hard decision to make, but of course, since this is a team effort, you have to ask for experts' help, especially if it's a difficult one to consider, if it's really a stroke or not, or if it's a borderline patient for thrombolysis. So you have to seek an expert opinion as well. Now, this is just the clinical pathway that we use in Calamba Medical Center for stroke patients. So when the brain attack team is called, so we have to be there within 15 minutes, and the hospitalist or neurologist have to check the ABCs, the time of onset, and they have to do the NIHSS or the stroke scales. As for the nurses, they check the BP, the heart rate, O2 sat, and temperature. And ideally, you have to have 2 IV access. We check for the blood, CBCs, cardiac markers if needed, electrolyte panel, and the renal function, coagulation tests as well, and then ECG. So within 20 minutes, ideally, a CT scan or MRI should have been done. And within 60 minutes, decision should be made. So I have to check if the ischemic stroke is less than 1/3 the MCA territory, then you have to proceed with thrombolysis. The patient is eligible. For transient ischemic attack, then you have to go to general stroke measures. And for ischemic strokes, this is more than 1/3 MCA territory, again, we have to proceed with general stroke measures. And for hemorrhages, we have to consult neurosurgeon. Ideally, within 3 hours, the patient has to be admitted to the stroke unit. So as you can see, these are the parameters in which we have to be on time, because as you have said, time is brain. More and more neurons are lost if we lose more time. So you have to be on schedule. Now, let's go to the management of stroke by its severity. Again, just a review. The NAHSS interpretation for minor stroke, it is NAHSS 1 to 4. Moderate stroke is 5 to 15. Moderate to severe is 15 to 20. And severe stroke is 21 to 42. So for mild ischemic stroke, you have to provide basic ABCs. And again, we have to check its vital signs and neurovital signs as well. And we have to check the stroke scales, NIHSS, GCS. And we have to manage the BP. We treat the BP, it goes up more than 220 systolic or more than 120 diastolic or MAP of more than 130. So this is the standard procedure that we do in each kind of stroke. As for the precautions, we have to avoid drop in BP. We have to avoid the use of rapid-acting sublingual agents when needed, and we have to use easily titratable IV antihypertensive medications. Oral antihypertensive medications we don't have, I think, locally, but IV, yes. And we have to ensure proper hydration, and if needed, we have to use plain NSS, 0.9 NaCl. And I have highlighted here the use of aspirin, 160 to 325 milligrams per day. And also we have to consider anticoagulation if needed. So if it's a thrombotic stroke, we have to give aspirin or its counterparts, ideally within 24 hours, and anticoagulation if it's an embolic stroke. Now, for mild hemorrhagic stroke, again, the same intervention, ABCs, vitals, stroke scales, and manage the BP. Early neurologist or neurosurgeon referral is needed. Of course, this is a hemorrhagic stroke. It's different from an infarct. So we have to be more careful because the brain bleeds easily. And it's not like the skin or some muscles or some tissues that if it bleeds, it usually stops in a few moments, a few hours, a few days. But for the brain, it's not like that. The brain is a soft tissue, so it bleeds easily. That's why we have to seek a neurosurgeon or neurologist as soon as possible. As for moderate ischemic stroke, again, ABCs, NAHSS, the stroke scales, vital signs, manage the BP, and put here that we can consider IV thrombolysis if needed. If the patient is not a candidate for thrombolysis, then we can give aspirin or its counterparts or anticoagulation. Now, for IV thrombolysis, we use alteplase. It is a medicine that we use for stroke, for acute stroke, and this is also called a clot buster. So what it does is a alteplase acts on plasminogen. So it acts on plasminogen, making it activates plasminogen and into plasmin, and then it makes the it splits or degrades the fibrin, so it removes the clot or dissolves the clot. So this is a study that prolongs the use of alteplase because at first alteplase was used within 3 hours of stroke, but they have studied it again, and they have extended its use to 4.5 hours of stroke. Now, for thrombolytic therapy, uses rTPA or alteplase within 3 to 4.5 hours of stroke. And in patients, at least 30% you'll have minimal or no disability at 3 months. So this is like a wonder drug, really. And if you're to use it, then you can say that it really is a miracle drug because usually patients that we have given alteplase, they can walk, and for NHSS, around 80 to 90% of them lose its deficits, so they're almost back to normal. So it really is a wonder drug. Its dose is 0.9 milligrams per kilo. This is the studied dose. Some neurologists, especially the Japanese and some Filipino neurologists, give a lower dose because they say patients are smaller in frame, the BMI is smaller. So sometimes they give 0.6, 0.7, 0.8 milligrams per kilo, but the indicated use is 0.9 milligrams per kilo. So 10% of the total dose should be administered as an initial bolus over 1 minute, and the remaining treatment dose should be infused IV over 60 minutes. Of course, before giving alteplase, you have to see if the patient is eligible for alteplase infusion. So you have to check for its contraindications. If there's a current intracranial hemorrhage or subarachnoid hemorrhage or any kind of bleeding, you cannot give it. For recent or within 3 months of spinal surgery or intracranial surgery or serious head trauma, you don't give it. For any condition that increases the risk of bleeding, like neoplasms, AVMs, or aneurysms, again, we don't give it. For uncontrolled hypertension as well, because increases the risk of bleeding. Now, let's go to moderate hemorrhagic stroke. So again, for moderate hemorrhagic stroke, you have to do the usual tests and management for stroke, and then again, early neurologist or neurosurgeon referral. For severe ischemic stroke, well, we may give aspirin or anticoagulation. So as I've written here, may give, because sometimes some patients have an increased risk of stroke. So we don't give aspirin or antiplatelets, or we don't anticoagulate because it might worsen or it might increase the risk of hemorrhagic transformation. So we don't give aspirin left and right if it's a severe ischemic stroke, but we may consider it. Okay. And for severe hemorrhagic stroke, again, neurosurgeon, neurologist referral, and usually give mannitol for brain edema. Now, I would like to talk about the stroke unit because when the patient is treated after giving the bolus in the emergency room, the patient is brought to the acute stroke unit. So what's a stroke unit? Well, it is a hospital unit that cares for stroke patients exclusively with a specially trained staff and a multidisciplinary approach to treatment and care. And in Calamba Medical Center, we have an acute stroke unit, and its goals are to improve chances of survival. Well, that's one of them. Another is to reduce the disability and to shorten the length of hospital stay and rehabilitation. And studies have shown these goals. And as you have seen in most patients who stay in the acute stroke unit, they are discharged earlier than patients who were not admitted at the stroke unit. Now, the task is, of course, to admit within the unstable phase, to monitor the vital signs and neuroparameters and we have to treat and to prevent another stroke. That's why we admit them to an acute stroke unit. And in our stroke unit, we have 2 dedicated beds. We have an emergency lab facility who manages the laboratory tests 24 hours a day. We also have a monitoring equipment, PPO to saturation, and respiration. And also, after all of those, once the patient is stable, then we can refer the patient to rehabilitation service. So either they undergo physical therapy or occupational therapy, whichever is needed for the patient. Thank you.
Thank you, Dr. Mark Palanginan, for that very informative yet brief review of the stroke process, as well as different options for management and the updates for rTPA administration. As a certified stroke nurse myself, I would like to share a few insights on how we can regard stroke management. But now let's focus more on the nursing aspect of it. So let me just share my slide. It will just be brief, so bear with me. Yeah. Next slide. Please bear with us. We're just having some few technical glitches. While waiting, just a few reminders for our participants. If you have questions, you can now's the time for you to key in their chat box so we can address it later. Or if you wish to participate, you could just raise your hand later on during open forum so we can hear from you later on. As a certified stroke nurse, I will be exploring the role of nurses in stroke management and how we can develop our competencies into 4 major nursing roles. As a patient advocate, a nurse educator, a nurse practitioner, and a critical care nurse. As a patient advocate, we can advocate for our patients through prevention of stroke. And how we can do that with simple modifications in lifestyles, like keeping your blood pressure low, lower your cholesterol levels, eating healthy, exercise regularly, trying to treat sleep apnea, as well as managing your diabetes, because as we all know, diabetes is one of those diseases that can greatly progress into or complicate other problems like in stroke. Also, lifestyle choices, we should avoid or drink in moderation. For those smokers, it is advised to quit smoking and avoid stress as well. And generally, maintaining a healthy lifestyle or a healthy weight so that we, as mentioned by Dr. Palanginan a while ago, these are modifiable risk factors that we can address so that we can prevent stroke. Also, we can empower our patients as a nurse educator, putting an emphasis on the BFAS assessment, as mentioned a while ago. As nurses, it is within us to acknowledge stroke and address it on a timely manner. And BFAS is an assessment tool that we can use to determine signs that the patient is experiencing stroke. So B stands for balance, eyes, F is for the face, A, arms if there are deficits in strength, S is for speech, and last and definitely not the least is T for time, which is emphasized a couple of times by doctor because as we all know and as he mentioned, time is brain. As a nurse practitioner, nursing priorities in caring for stroke management involves our nursing assessment, proper positioning of the patient to prevent bed sores, maintaining mobility through passive range of motion exercises, encouraging our patients to dangle if they can, or exercise their affected limbs. This also improves their balance. Also, a focus on personal hygiene is emphasized because it prevents infection for our patients and improve their outcomes as well. And lastly, as a critical care nurse, this one involves the nursing priorities in giving rTPA administration. As mentioned, rTPA is a drug of choice for thrombolytic strokes, and most often, it imposes risk to our patients. So, which is why it's important for us nurses to know when to give it and how to give it properly. So before infusion, here in our institution, we practice we complete an eligibility checklist if the patient is eligible to receive rTPA, followed by an well-informed consent. So through here, we will explain to the patient the risk involved in receiving such medications, as well as possible outcomes. Also, ensuring that the IV lines are patent, and make sure to insert NGP and intrafolic catheter insertion, indwelling Foley catheters if deemed necessary. During infusion of the rTPA, it is important to note for the correct dosage and preparation. As mentioned by Dr. Palanginan, the initial bolus will be given over a minute with the remaining 0.9% infused over an hour. So it is important for us to know the patient weight, proper computation of medications, as well as preparation, and ensuring that the route of administration is maintained and sterile. And lastly, after infusion, we need to flush the tubings or the bag of the rTPA. This is to ensure that all medications are delivered to the patient, even on the tubings, so the patient will receive the exact dosage prescribed by our doctors, and proper documentation of the dosing, any abnormal signs and symptoms that the patient may experience, or the time you finish infusion. It is also important to note that no invasive procedure is expected to be done to the patient within the first 24 hours, which is why before the infusion, we highly encourage the nurses, if there are possible blood extractions, insertions of different catheters like NGT or Folicat to be done prior, so that we can rest the patient of such after the infusion. And some special responsibilities lang, make sure to monitor vital signs and your vital signs of the patient, watch out for bleeding, headache, dizziness, nausea, or vomiting, complete bed rest at all times, and in case the patient experiences deterioration, we must stop the infusion immediately of the rTPA, inform our stroke service, our doctors, or the hospitalists in your institutions, and obtain an immediate CT scan to note for possible conversion of an infarction into a bleed. And they check for bleeding parameters as well. And as a precaution, we may consider preparing 6 to 8 units of platelet concentration if the patient manifests bleeding. And as mentioned by Dr. Palanginan as well, possible hematology or neurosurgery referral is necessary. Ayun. I hope our viewers have learned something to further our nursing careers as well as our competencies. It is also our time to take part in spreading the word that we can catch stroke early in our communities and treat them accordingly to improve our patient outcomes. Now, we will proceed to the open forum or the Q&A where we will be answering some of your questions. So let me ask Dr. Palanginan, and I will be reading some questions from our viewers po. First question, Doc. How often does a stroke patient can receive thrombolysis?
Do you mean if he or she can still be given
A
second one or
yes,
a third
Doc.
one?
Yes, Doc. Most definitely that is the intention of the question.
Yes, yes. As long as they fit the indication, they can still be given indefinitely. So there's no specific number of times given. As long as they fit the indication and a contraindication. So there is none.
That is duly noted, Doc. We have a question. Dr. Alzate, our professors, Dr. Palanginan wants to ask a question. Yes, po.
Right.
Dr. Alzate, you can open your mic for questions, sir. Yeah. While waiting for Dr. Alzate, I saw someone raising his hand. Sir Ryan, do you have a question?
Hi guys. So just to clarify things out regarding the stroke management. So as I recall, I've asked Dr. Palanginan when I was still part of Calamo Medica that which is better, the anti-embolic stockings or sequential compression device? Because as per my recollection back in the Philippines, we are using anti-embolic stacking as compared to sequential compression device. Where in fact here, what I have observed is they strip off the anti-embolic stockings and they really transition to sequential compression devices. My question is, Doc Palanginan, I know the white paper that you have provided to us is highly reliable. What are the things that limits the nursing the management of patient in using sequential compression devices for them, and we are still continuing the use of anti-embolic device?
Well, thank you for the question, Ryan. First off, of course, it depends on the hospital. If they have the intermittent stockings available. Most of our hospitals here in the country, especially in the provinces, do not have access to intermittent stockings, pneumatic stockings. So next best thing would be an anti-embolic stockings. And anti-embolic stockings have been proven to help lessen the chances of thrombosis before. But there are current studies now that they don't actually help as much as we think. So that's right. They advocate now the use of pneumatic compression devices. But again, in our country, it is difficult to attain because, of course, it depends on the hospital. If the hospital will avail one or several devices, ideally, they must. But of course, you cannot dictate some hospitals. So the next best thing would be, anti-embolic stockings, frequent turning, passive exercises. That's the best thing we could do here because, of course, third world problems. But ideally, we need to have intermittent compression stockings.
Thank you, Doc.
I hope that answers your question, Sir Ryan. Here's another question, Doc. How can cardiac disease precipitate stroke? Or yeah.
Cardiac
Mili-
disease, yes. When it comes to cardiac diseases, the usual uh, factor is an atrial fibrillation. So if the patient has an atrial fibrillation, of course, atrial fibrillation is the uh, tachyarrhythmia of the heart. And what it does is when it pumps irregularly, it forms the heart, inside the heart, it forms a blood clot inside the heart because of the stasis of blood inside the heart. So if the clot forms inside the heart and then the heart pumps one big or one massive pump, the blood clot can go out of the heart and lodge into the artery of the brain. And that's the usual cause of uh, stroke in patients with atrial fibrillation. Sometimes we have patients with patent foramen ovale, or they have a valve diseases, which can also precipitate stasis of blood inside the heart. So we have rheumatic fever, mitral valve stenosis, and rheumatic heart disease. So these patients can develop blood clots inside the heart, which in turn embolizes to other parts of the body, most especially in the brain, which may cause the stroke.
Thank you, Doc, for that. Um, from our participants, would someone want to ask questions to Dr. Palanginan? You can raise your hand or unmute yourselves if you want to ask questions. Let me read a question from our chat box, Doc. Good PM. Thank you for a very informative lecture. I would like to ask to explore more with other contraindications for thrombolytic therapy besides bleeding problems. Doc. Other contraindications of thrombolytic therapy besides bleeding. Doc, you are on mute po.
Okay, thank you. Besides bleeding, so if there's a previous or recent history of surgery, uh, intracranial or spinal surgery within 3 months, or a serious head trauma there, so those are few contraindications, as well as a very high blood pressure. So those are some of the contraindications for thrombolysis.
Thank you, Doc. Thank you, Sir Martin, for that question. Any other questions from our participants? Yeah, good afternoon again. Let me get back at one of our viewers who is going to ask a question. Dr. Agatot, are you free now? Dr. Agaton, are you saying something po? Ayan. We have here's the question, Dr. Palanginan. When to use wire coiling?
Coiling. Okay.
Yes, Doc.
We use coiling in cases of ruptured aneurysm of the brain. So what we do is we insert the coil into the artery, sometimes in the inguinal artery or the wrist, and then We bring it up to the brain intracranially. We bring it up to the area where there is an aneurysm, and then put it inside the aneurysm, and then it stays there for the duration of the patient's life. So in neurology, that's when we use the coil.
Thank you, Dr. Palanginan. I hope that answers your question, Sir Agaton. Again, if there are no other questions, we are incoming question po, sorry. If another question, Doc, if the patient is on heparin or apixaban as VTE prophylaxis, will the patient be eligible for rTPA?
Yes and no. So if the patient has an apixaban or other NOACs which do not have a reversal agent, usually we don't give thrombolysis. We don't thrombolyze. As for the bigatran, we have a reversal agent available. So if we see that the patient has a stroke and it is that the patient is thrombolizable but is on the bigatran, first we give the reversal agent or the antidote for the bigatran, and then once we have given it, we can assume that the bigatran level in the blood has lessened or decreased, then we can thrombolyze, assuming that it is within that time frame.
Yeah, thank you, Dr. Palanginan. Thank you.
Yes, it's a tricky question actually, and it is a case-to-case basis, case-to-case basis. So, but usually we give it to patients in with the bigatran because the bigatran has a reversal agent.
Thank you, Doc. Maybe for our last question, I just learned that thrombolytics are contraindicated for pregnant patients. Maybe you know what alternative management we can offer to them.
As for pregnant patients, unfortunately, we don't have an alternative for alteplase or IV thrombolysis. Of course, they didn't study alteplase in pregnant patients because of its ethical reasons. But in some studies with alteplase in rabbits, in pregnant rabbits, some have found that the alteplase can be embryocidal. And of course, pregnancy can increase the risk of bleeding as well. So even though if they don't have any study when it comes to pregnant patients with stroke who are thrombolizable, we don't give it for the said reasons. But if the patient comes and she's thrombolizable but she's pregnant, we don't offer IV thrombolysis. But what we can offer is other parameters such as secondary prevention for stroke, no, and of course, if the patient is pregnant, and we have to check for the risk factors of the patient. Being pregnant also makes the blood thicker, and so we have to check also if the patient has blood disorder or a cardiac problem, because of course, patient is young, patient is of a fertile age. So you have to check for other parameters. Why did she have a stroke? And maybe we can focus more on the cause of the stroke than rather than the giving of thrombolysis.
Yeah, thank you, Dr. Palanginan, for that. I already said that would be the last, but here's another question, Doc, if you don't mind.
Okay.
What is the golden period for stroke patient to undergo surgery?
Surgery of the brain?
Yes, po, Doc.
Okay. What kind of surgery?
There's nothing specific. about the question, Daki. But,
Okay.
ayun.
There is no golden period actually when it comes to intracranial hemorrhages. Is that what you're saying? Or massive infarctions? It depends on the patient's condition. It depends on the surgeon's availability, of course. But there's no golden period. It depends on the patient's status. If we see that the patient is deteriorating in front of us, then we have to do an emergency surgery. But if you're asking about the thrombectomy, which we don't have here in Calamba, in some institutions in Manila, they can do it. In St. Luke's, in Makati Med, I think. Thrombectomy, it's up to 6 hours. So if that stroke patient comes within 6 hours and they do not, we cannot thrombolize the patient because it has passed the golden period, then we can do thrombectomy within 6 hours. But of course, it's just in selected hospitals in Manila. So I hope I answered your question.
Yes, thank you. Again, thank you, Dr. Palanginan, for sharing your precious time with us this afternoon. If there are no other concerns, let me present the certificate of appreciation to you, Doc. Just let me read the citation. Philippine Women's University hereby awards this certificate of appreciation to Dr. Mark Christopher Palanginan for sharing his outstanding knowledge and valuable expertise in the webinar entitled Advancing the Core Competency of Nurses, Acute Stroke Management and rTPA Administration, given this 29th day of June at the Philippine Women's University, Manila, Philippines. Signed by Mr. Yancy Kent Garcia, event chairperson, our course advisor, Dr. Agaton Alzate, and the Dean of the School of Nursing, Ms. Minerva de Ala. Thank you, Doc.
Thank you. Thank you for having me.
It is our honor, Doc. Now, for the closing remarks, I give the floor to one of the head nurses at Calamba Medical Center and also a facilitator of this event, Ms. Novi Amrad.
Thank you, Sir Ralph. A pleasant afternoon to all. On behalf of the Calamba Medical Center students and their Master of Arts in Nursing, major in MS, I would like to take this opportunity to thank everyone who made this webinar possible and successful. Thank you to our beloved Dean, Dean Minerva de Ala, our very supportive course advisor, Dr. Agaton Alzate Jr., to our dear speakers, our very own Sir Ralph Alcantara and Dr. Mark Palanginan. Despite a hectic schedule, you still supported us on this webinar. Given your precious time and effort, and for that, we really appreciate you. And I would like to pay my deep respect to all the participants for your positive participation in this webinar. And also thank you very much to PWU Multimedia and ICT for helping us on this webinar. It is my great pleasure that we had a fruitful discussion, though I think 1.5 hours is not enough. I hope that we learned a lot from our discussion, so I can conclude that the purpose of this webinar has been completely accomplished. I hope that what we learned on this webinar will help us a lot in dealing with stroke patients in the future. Above all, we give God the glory. Again, thank you and good afternoon.
Thank you, Ms. Ambrad, for that message. As mentioned, here is the post-evaluation link. So guys, please scan the QR code and click the link below posted on the chat or the link posted in the screen. And we will be providing certificates that will be emailed to our participants. In behalf of my classmates, the facilitators of this event, and our ever supportive professor, Mr. Agaton Alzate, we extend our deepest gratitude to all of our viewers and participants for joining us this afternoon and hopefully help us educate more people about stroke and be reminded that illness should not be a life sentence, but rather a motivation to always strive for excellence in healthcare and improving one's competency. Again, thank you and enjoy the rest of your day. This has been Ralph Arvin Alcantara, your moderator for today. Hoping to see you later in our next session. Our next session will start at 3:30 p.m. So if you haven't registered yet, posted are the links and the registration links. Again, thank you and God bless.